today's presentation. So it gives me tremendous pleasure to introduce my colleagues, Dr. Colleen Kraft and Dr. Michael Woodworth, who are going to present grand rounds today. I think Dr. Kraft is going to start us out. She is an associate professor of medicine and infectious disease and also in laboratory and clinical pathology, clinical laboratory and pathology, clinical laboratory. She's associate professor in the Department of Pathology and is also the associate chief medical officer at Emory University Hospital, as well as the associate medical director of the serious communicable disease unit. Colleen was, of course, instrumental in the Ebola response and the continuing response to serious communicable disease, but having known her before all that hilaria, the microbiome has been the core of her heart since I first met you, pretty much. And so I'm delighted that you're getting back to your core here to talk about clinical microbiome interventions. Mike Woodworth has been on faculty for a year and a half, or no, less than a year. I'm really doing a great job here this morning. He is an assistant professor of medicine and infectious disease. He was a Duke resident and then completed a combined fellowship in infectious disease between the University of California, San Francisco, until he saw the light and came to Emory to complete his fellowship. And we are delighted that he joined faculty. He is also a winner of a K23 award and is now beginning his research career in the microbiome under Dr. Kraft's mentorship. So I'm delighted to welcome the two of them up here to tell us 5 myths about clinical microbiome interventions.
I should also say that Mike got in the top 1 percentile on his score. So, and it's more like a dual mentorship rather than one versus the other. All right. We have we're going to start with a case. 50-year-old woman with end-stage renal disease due to type 1 diabetes is status post living unrelated donor renal transplant about 5 years ago. Her post-transplant course was complicated, just going to say that. And she's been admitted again with diarrhea and tested C. diff. And we won't get into C. diff testing today, although that's really fascinating to me. Her nursing home providers ask, is she a candidate for fecal microbiota transplant? What benefits other than cure of recurrent C. diff might she expect from a fecal transplant? And how does fecal transplant work? So we're going to try to address some of these issues and topics during this talk. So this is really hard for me. I think it's activated. So we're going to try this poll everywhere. We're going to do this throughout the talk. So what do you think about when you think of fecal transplant? Please keep it PG or G only, or I will just have to shut this down. Apparently nobody cares, but that's cool. All right, I don't know what. Woodworth, that's good. Oh, I like the poop emoji. That was a really good idea. Quackery, I like that. We'll try to address that. Promising. Some of these are a little MDRO. I finally figured that out. This looked like an Indian word to me. Okay, thanks. This is to get us practice for the future ones. So we're going to be covering our 5 myths. They are experienced here in graphical form. So we're going to talk about, so I'll just get you ready for what you might answer. So we'll talk about, is FDA approval, fecal transplants are FDA approved. The second graphic here is patients do not want a fecal transplant. The third one is fecal transplant is a substitute for good diet and exercise. Number 4 is fecal transplant is only for C. diff infection. And number 5, all we care about in fecal transplant is bacteria. So those are going to be our 5 myths we're going to talk about. So we had this idea to kind of go off PolitiFact, but we've made it stool fact instead of PolitiFact, because everybody probably has had enough of the political climate as of late. So your choices are going to be on our myths: true, mostly true, half true, mostly false, false, or pants on fire. And I just think about Princess Bride with this, like mostly dead, totally dead, whatever it was. Okay, anyway, so this is trademarked by us, stool fact, truthometer. Okay, so our first, now we're saying myths, so it does kind of get you into the maybe none of these will be true, but we won't go there. So fecal microbiota transplantation is FDA approved. So is that true? Mostly true, half true, mostly false, false, pants on fire. Okay, so the majority say that that is true. I'm glad we're speaking today. That is a very much pants on fire on the truthometer. So let's talk about a little bit of the background to the FDA response to FMT. And now you're looking at these dates and saying, well, this is quite old information, but it actually is still relevant to what we're doing today. So in May of 2013, the FDA met and said that they wanted an IND application is needed for the use of FMT to treat any disease, including C. diff infection. Is an IND easy or hard to get from the FDA? Yeah, this is probably the wrong way to ask the question, but it's a very time-intensive process. So there's actually quite an outcry by many advocacy groups and patients themselves who had received FMT. And so actually in June of 2013, the FDA revised their guidance and they said that they would exercise something called enforcement discretion. And this is something that's important for you to realize because it does need to put the risk on the provider. And so the FDA at any time can come in and look at what's being done if there is a concern for an adverse event from a fecal transplant. So the enforcement discretion allows you it provides that the treating physician obtains adequate informed consent from the patient. And we'll see a little bit of that language later. But basically, you need to tell the patients that this is an experimental therapeutic and that it's not FDA approved, hence the pants on fire, right? There are two very interesting draft guidances, and actually this is causing Emory to sort of rethink. We used to have our own stool bank, but we're thinking about going back to it because of these two not enforced draft guidances. Why does the FDA put out draft guidances and then not enforce them or not finalize them? Part of it is that they sort of want their information to be known, maybe their position to be known, but realizing that they don't have enough data or influence to be able to enforce those guidances. So this is still what is out there, but the FDA doesn't actually finalize this opinion that they have. So in March of 2014, the FMT product obtained from the donor should be known to either the patient or the treating provider, and that the stool has to be basically screened and tested under the licensed provider. And then in March of 2016, they really added that they didn't want it from a stool bank. Does anybody know where most of the fecal transplants are sourced from in this country? Anybody know the name of the company? Open Biome, right? It's in Cambridge, and they send out the most fecal transplants probably of all stool banks in the United States. And so this has not been enforced against them, but they are aware of the dynamic with FDA and continue to sort of release their data to try to have them not enforce this. So why is the FDA concerned? And I will argue why it will never be FDA approved. It's a pretty not standardized substance. If you've ever mixed poop like I have, or taken a lot of aliquots of poop over the years, it's a rainbow of colors. It's a rainbow of different kinds of textures, and so it's not something that you can really standardize. And so one of their main things, though, is about long-term effects. So we don't really understand if you put one person's stool into another, is there something immunologically that happens? It's the largest immune organ, right? And so it includes the possibility that inflammatory, allergic, or metabolic conditions could be related. One of these was highlighted in this case report from Colleen Kelly out in Brown. It was kind of interesting because basically the mother got a fecal transplant from the daughter who was obese, and so then the mother became obese. This throws into, this is the kind of stuff that the FDA wants to read through and understand and they want reported. But for those of us that are in the field, it's also a little artificial because all of the patients that we've seen, most of the patients that we've seen, that after having years of chronic diarrhea from C. diff, most of them gain weight because they're not having chronic diarrhea. So it's a little bit trying to figure out, what is the effect of the fecal transplant and what's the effect of just eliminating C. diff, for instance. If you are not aware of this, I guess you probably don't pay attention to fecal transplant stuff, but the FDA issued a safety warning in June of 2019. 2 individuals died after receiving fecal transplants that had ESBL E. coli in the fecal transplants from the same donor. I will tell you, they didn't say much for about 4 months about where it happened and under what circumstances. Both of these individuals were very immunocompromised. This has been published in the New England Journal by Libby Holman. One had severe liver failure, and I think the other one had a bone marrow transplant, and they were getting fecal transplants for other than C. diff, although that's a little bit of a spoiler alert for future questions. Sorry, Mike. So these were people that we here at Emory might have been a little bit reticent to transplant potentially, but also the ESBL was unusually found in somebody that didn't have any risk factors. So one of the things the FDA has put out is that they really want you to address with your donors what the risk factors are for colonization of MDROs, except we, among those who culture poop a lot and think about poop and colonization, are not really clear that there's a lot of specific risk. Like, for instance, healthcare workers are excluded. And I will tell you that I do like to use some quasi-healthcare workers from, because they're coming to the hospital anyways, they might as well bring their poop with them as being donors. And so those types of individuals who have any contact with patients cannot be used as donors, but we really don't really know the prevalence of MDROs in these individuals in these populations. And then obviously, besides screening for a high-risk donor, you also need to be able to exclude drug-resistant bacteria in the stool by specific testing, which, by the way, most places don't do. We do because that's a high area of interest, as you'll hear later from Mike. I had the opportunity to speak at the November 2019 FDA listening session called The Use of Fecal Microbiota Transplantation to Treat Clostridium difficile Infection Not Responsive to Standard Therapies. And this really was a response to that June 2019 release of the warning. And it was really an interesting, if you ever get a chance to go to one of those, I highly recommend it. If you get a chance to speak, it was also a good / stressful experience. But what I found there and what I saw there was there were a lot of companies that were trying to make fecal transplant surrogates. And so their side of the tug of war was that fecal transplant, which they want to be not really allowed or only under IND again, like back in March of 2013. They believe that when you give people this therapeutic that's never going to be FDA approved, it does not allow other therapeutics to be tested because people go right to this not FDA approved treatment that's just under this enforcement discretion. However, on the other side, a lot of clinicians that run the clinical trials were saying that not all patients will meet criteria for a therapeutic clinical trial. So I think we live in a really fascinating time right now to know and to be watching microbiome intervention. So I know that you're all riveted at the edge of your seat, but it will be interesting to look back on this decade and see sort of where we started and where we end up with how these things are licensed, treated. We yet don't have anything that is licensed or FDA approved for C. diff that is a microbiome therapeutic. There are people that are very close to trying to get that approval, but they're struggling with enrollment because most people just want the fecal transplant. So how can FMT be used clinically right now? So it can only be used for medically refractory or recurrent C. diff infection under FDA enforcement discretion. So this is not an FDA approved treatment. And all other indications for using fecal transplant must have an IND. Okay, we're going to go to our second statement. So patients won't want a fecal transplant. All right, you guys are getting the gist of this. They're myths, so probably none should be true. So there was an interesting article all the way back in 2012, sort of when things were starting more heavily prevalent in this country for doing fecal transplants. Back when I was a fellow, we just joked about it, not that it was that long ago. But they did this was an interesting study because this wasn't individuals that actually had undergone a fecal transplant. And when we were just starting our program in 2012, I had a lot of people asking me, who wants this? And I said, if you had diarrhea for 2 years, you would be open to getting a fecal transplant. So these were individuals, though, that had not really undergone it. It was just a survey. But you can see that they read 2 scenarios, and they had an option of having sort of floral restoration versus antibiotics. And so most of them liked the idea of having sort of a microbiome adjunct to their treatment. And I think that's pretty much held true to today. Obviously, people want a odorless pill or an odorless liquid. So those are very specific aspects to this. So we work on that, but it's not always the case. We also decided in our own manuscript where we looked at durability and long-term clinical outcomes. Emory, for a while we had our own stool bank, was actually was among the institutions that did the most FMTs at the time. Currently, we've done about 420 at our institution, which is a pretty large cohort. And so we looked back and saw what caused people to get C. diff again after they'd had fecal transplant, and then did anything else happen to them? This whole sort of getting at the question of the FDA and the long-term effects. And so basically, not surprisingly, antibiotic use after getting your gut garden restored with a fecal transplant leads you to have C. diff again. So this wasn't like earth-shatteringly knowledge, but it really helped us to understand that this is sort of our counseling that we give our patients. They end up being very good advocates for themselves about really asking, do I really need these antibiotics for this sinus infection or for this urinary tract infection? Do I need something around this procedure? So they're very good at sort of calling us back and saying, what should I do in this case? I just had someone text me the other day asking very, very question. And so we looked at the other things that are mentioned here. Obviously, hospitalization often correlates with antibiotic use, and so that's also a risk factor for getting C. diff again. But one of the great things I think that Mike for sure wanted to add to our survey was just whether or not they were willing to repeat the fecal transplant. So this is very real world data. This is more like effectiveness or sort of willingness. And so really 95% of them were willing to repeat this FMT if C. diff recurred, which we were happy about. That means they had a good experience here. However, if you even look farther, there were some people that actually preferred fecal transplant. So 70% of that 95% preferred to just have fecal transplant to antibiotics, which says a lot about how they feel the efficacy of antibiotics works before they get their gut garden replanted. So I would say consider FMT as a treatment, an early line treatment in your patients with recurrent C. diff, and you can refer them to myself, Tom V. Deer, or Ed Levert at St. Joe's. All right, this is your turn. Oh no, this is the answer. Mostly false, as we've said. Okay.
All right, so I'll be taking over for the next 3 myths here. And so myth number 3 is that FMT will make good diet and exercise obsolete. And so if you could answer with your poll everywhere response. I'll say that this is a secret fear of mine as a researcher in the microbiome space, that it will all turn out to just be diet and exercise effects like everything else in medicine. But great. Okay, so 65% think pants on fire. Wonderful. So so we've known for a long time that diet and exercise are associated with a number of clinically important conditions. And so there's a lot that's come out over the last several years about the microbiome and a specific metabolite called TMAO and the risk of cardiovascular disease. And so I'll spend a little bit of time telling you some of that story. And here's a nice summary illustration that was from the New England Journal. And basically, when we eat animal proteins that are high in phosphatidylcholine, that choline then gets subsequently metabolized by our intestinal microbiota into trimethylamine, which is then processed by the liver to this metabolite TMAO, or trimethylamine N oxide, which you can see why we call it TMAO. And it's been shown in several studies now that high levels of TMAO increases your risk of atherosclerosis, as well as important cardiovascular composite endpoints. So this was a paper that was from 2016, where they had several nice looks at large blocks of evidence. And in the first line of their work, what they did is they looked at a large cohort of patients in Cleveland who were undergoing elective coronary angiography. And then they just took plasma samples and measured their TMAO levels and broke them up into quartiles. And you can see a pretty strong dose response curve here, and all the Kaplan-Meier estimates for freedom from MI or stroke break out nicely by TMAO levels, with those in the group with the lowest TMAO levels having, being the reference, but those with the highest TMAO quartile having the highest hazard for an MI or stroke. So this was kind of, retrospective human level data. And then they went to some mouse models to see if they could get at this question a little bit more. And what they did is they took, healthy mice and administered TMAO directly compared to a vehicle. And they saw reductions in thrombosis time. So they had clots much more quickly when they were administered TMAO. And then on the right-hand side, you can see just sort of the opposite side of that, of just measurement of time to cessation of blood flow, with a much shorter time to cessation of blood flow with administration of TMAO. So then what I think was especially interesting about this study was they wanted to ask, how transferable is this trait? And so they had done other work to find that in 20 different cohorts of mice, that some of them are higher producers of TMAO naturally than others. And so this black mouse here illustrated at the top was from a black 6 mouse cohort that they identified as being high TMAO producers, just kind of on their own. And then in the bottom here is this other mouse cohort that was identified to be a low TMAO producing cohort. What they did is then took cecal contents from these mice and then transplanted them into germ-free mice. And then from each of these transplanted germ-free mice, they fed them either a diet high or low in choline to see in vivo what the effect of in vivo TMAO production would be in the context of these transplanted microbiota. And they saw the same thing. And so on the left-hand side, you can see here on the y-axis, the platelet aggregation measure. And so you can see in these TMA-producing mice fed a high choline diet, that there was much higher rates of platelet aggregation compared to those fed a low choline diet. And the mice that had stool that was transplanted from low TMA-producing mice, they weren't able to have the same effect when fed choline. And so you can see that this is essentially a transplantable phenotype here. And so this is just another kind of way of looking at similar data at time to cessation of blood flow, that the same mice when fed choline had shorter time to cessation of blood flow compared to those that were not fed choline. And that the mice who received microbiota from low TMA producing microbiota mice did not really have the same phenotype when fed choline. So this suggests that this phenotype is something you could transfer, with something like a fecal transplant. The question then comes, all right, so that's nice to see in a mouse, but what can you do for humans? And can we potentially make diet and exercise obsolete for cardiovascular endpoints, which would be nice for all of us, I think. So this group sought out to transplant stool from vegan healthy donors into patients with metabolic syndrome. And they had several endpoints that they looked at, including plasma TMAO levels, and they took a measure of atherosclerosis activity with PET CT. So I'll kind of cut to the chase here and show that this was actually a largely negative study. But what they did is the recipients with metabolic syndrome, as a control, they performed autologous FMT. So they took stool samples, processed them for administration back to themselves as a control. And in the intervention group, they were given this FMT from vegan healthy donors. And so at baseline, you can see, unfortunately, that the metabolic syndrome patients, did not have a significant difference in Shannon diversity, which is one way to tell the difference in microbial communities over time. and that after FMT, that there was also not a significant difference from baseline. They did observe that some taxa that were identified as being differentially abundant in the vegan group were found in some of the transplanted patients afterwards. However, this was really the main difference that they were able to observe in the patients who got a vegan transplant. They then looked at TMAO metabolites in these patients who were treated with either an auto FMT or a donor FMT. And again, you can see that the baseline fasting plasma TMAO levels in those who were self-identified as vegan compared to those with metabolic syndrome, that their baseline plasma TMAO levels were actually not that different. And so then after either receiving autologous FMT where they got their own stool back, or after receiving the vegan donor FMT, that unfortunately they did not see any significant differences in TMAO at 2 weeks. So unfortunately, it does seem clear that the gut microbiome and its metabolites from animal proteins are strong contributors to atherosclerosis and cardiac events. And unfortunately, a first trial of FMT for atherosclerosis was unsuccessful. But there were important limitations in that study in that they actually didn't prescribe any specific dietary modifications for the recipients. In some of the comments in the fine text of the paper, they actually indicate that the vegans that they identified as donors weren't necessarily strict vegans. So for now, I think diet is still critically important, but certainly there's enough data to suggest this is a potential area of interest in the future. So we said this one is false for the most part. So myth number 4, FMT is used only for recurrent C. difficile infection. So if you could answer with your poll everywhere response. Great, all right, so Pants on Fire is the winner here. We'll move on to talk a little bit about one specific indication for which we're using FMT in our research program, and that's decolonization with antibiotic-resistant bacteria. As I mentioned in the last study that there's a lot of interest in cardiovascular disease. There's easily a dozen different diseases for which there is pretty reasonable rationale to think that FMT could work. But for this section of the talk, we'll just focus on antibiotic resistance, since that's what we do a lot of our work on. But in brief, for those who don't think about this all day, every day, antimicrobial resistance is truly a global threat. World Health Organization is doing its best to raise alarm bells by saying things like antibiotic resistance is the greatest threat to global health. And the CDC has recently updated its threat report, in which they've estimated that well over 35,000 patients a year are dying from these infections. And increasingly, there are cases such as this one that was published back in 2017, where isolates are being identified clinically that are totally resistant to every antibiotic that they can test in the lab. And unfortunately, this case, this woman died from her infection ultimately. And essentially, you can imagine being her doctor in the room and not really having an antibiotic that you can offer her. So this is a real clear and present issue. There is, though, exciting and interesting new data that is rapidly accumulating that says that microbiome therapies like fecal transplant are actually very effective at decolonizing patients who are colonized with antibiotic-resistant bacteria. And here's a concept illustration just to go briefly over why we think this is so. And on the far left-hand side, you can imagine a normal microbiome that's resistant to colonization, that's resistant, perhaps relatively abundant with anaerobic taxa that are protective from colonization with bad bugs. And that when you're exposed to antibiotics, that your microbiome then becomes disrupted and susceptible to colonization. And then after exposure to MDROs or multi-drug resistant organisms, that you then are at risk of colonization and dominance, and this can lead to downstream infection and transmission risk. And the idea of fecal transplant for this indication really is to, as directly as we know how, move patients from the right-hand side all the way over to the left-hand side back to where they're once again resistant to colonization and no longer actively colonized, and at risk of infection and transmission. There are several lines of data that have been published now to support all of this, but I'd like to just briefly review 3 lines so that it's familiar to this group. But the first is using a culture-independent approach. And this group noticed when they looked back at patients who were treated with a fecal transplant just for C. diff, that when they looked with gene sequencing techniques to just try to count the number of antibiotic resistance genes, that you can here in the second column see that patients before fecal transplant, or BFT, had a high count of antibiotic resistance genes, and that after a fecal transplant, that count was dramatically reduced. And of course, it doesn't go to 0 because there are plenty of taxa in our microbiomes that are abundant in antibiotic resistance genes, but the count certainly went down in this case. So this was a culture-independent approach that suggested this could work. And what about culture-based methods? And this is what we do clinically, so perhaps more relevant. And so now there are several studies that have looked at this endpoint. And there is some variability in the estimates of how often patients are decolonized, but they range somewhere between 40 and 90% of patients who are treated with an FMT are no longer colonized with an MDRO when they look with stool culture. And so this is, one of the largest effect sizes for this type of application that has been seen in the space in a long time. We've also been interested in whether or not FMT can reduce the recurrence of infections other than C. diff. And we worked with a medical student who published this case report with us a couple of years ago. And so, I would point to this as a third line of evidence that FMT could be effective for addressing antimicrobial resistance, because this patient had 25 years of recurrent urinary tract infections. And you can see this, this sort of crescendo that was happening here, where she was getting increasing antibiotic exposure. And not surprisingly, I think to this group, ended up developing C. difficile, and then it recurred multiple times, which led to her getting a fecal transplant. And then after that, she had no further urinary tract infections. So this is just an N of 1 with a little over 2 years of follow-up. But it was an especially dramatic case, which is why we published it. But there are other groups, such as this one at Mayo, that has gone back and looked at their patients, and they identified 8 similar patients to the one I just showed you, who had a history of both recurrent C. diff and recurrent urinary tract infections, and were treated with an FMT. And you can see these patients on the left-hand side, and you can see that their count of urinary tract infections after FMT went down. And then on the right-hand side, you can see 2 columns where they've presented matched control patients who had similar history of recurrent C. difficile infection and recurrent urinary tract infections who were not treated with an FMT. And you can see that in many of these cases, they actually had more urinary tract infections over that time period, although some also went down, but not to the same rate. So, so that's 3 lines of evidence of why we think FMT is an important treatment for antibiotic resistance and recurrent infections other than C. diff. So what are we doing about it here at Emory? Well, we've had a microbiome enrichment program since 2012, when co-founded by Colleen and Tanvi Deer. And really, there's 2 main branches of this program. There's the clinical program, which is focused on recurrent C. difficile infection, which is that cohort of over 400 patients that Colleen described. And then we have a research program, which is largely focused on investigator-initiated studies, where we're trying to develop our own protocols and kind of expand into new areas of research. These 2 programs are linked closely by our stool donor program. So again, we're actively recruiting donors who are not healthcare workers. So feel free to reach out to us if you think you know someone. As Colleen mentioned, regulatory status of all this work is in flux. And so we've done our best to maintain our own capacity for maintaining a stool bank. And that includes training of junior faculty and trainees such as myself to do this work going forward. And here's what our product looks like at this point. Although we've recently moved into the space to start to lyophilize and encapsulate and make our own pills. So here's a basic overview of premix, which is one of our main investigator-initiated studies where we focus a lot of our time and energy. And premix is a phase 1 study of renal transplant patients, just like the one that we presented to you at the beginning, who've had any history of infection with one of 4 different MDROs. And these patients are randomized in a 1-to-1 fashion, either to an observation period, which we call cycle 0, or to an FMT treatment period, which are cycles 1 and 2. And so at each one of several visits, we collect stool samples and check them to see if we can still grow an MDRO from stool culture. And we are also collecting PBMCs in plasma and serum and urine, and have lots and lots of plans for those analyses downstream. But at day 36, if we are unable to grow a stool culture, an MDRO from stool culture at day 36, then that patient is essentially done at that point. But if they're still positive, then everyone has the opportunity to continue on to another FMT cycle. So in brief, everyone in our study has the opportunity to get up to 2 FMT treatments, although half are randomized to start with an observation period. We then follow them all for 6 months afterwards to see if anything untoward shows up. So these are the 4 target MDROs, as we call them, for our premix study. And I'll show you this slide just to introduce them, because we'll be summarizing them very briefly, just as one letter, but they have very long names. And so in the top left, there's multi-drug resistant Pseudomonas. In the top right, we have extended spectrum beta-lactamase producing Enterobacteriaceae, which we call E. And then in the bottom right, there's carbapenem resistant Enterobacteriaceae, which we call C. And in the bottom left, there's vancomycin resistant Enterococcus, which I'll just be calling V. So here's a summary slide of just of our patients who've completed all their study visits. We're approaching 75% enrollment for this study, although I'm just presenting those who have completed their study visits to you today. And you can see that of the patients who were enrolled, all of them had clinical infections with ESBLs. But we've been surprised at how frequently these patients are subclinically co-colonized with other MDROs. And so some of them we've been found to have CRE or VRE just sort of lurking in wait in their intestines. And then of those 3 patients who were initially randomized to an observation period, none of them had any change in their MDRO colonization during that study period. However, once they were treated with an FMT, as shown in cycle 1, you can see that they start to lose their MDROs. And so I've represented a negative culture time point with a green square. And so you can see here that of the patients who were initially randomized to an FMT, that 4 of those 6 patients were negative at day 36. And then some of these patients, 3 of them, went on to get a second FMT because they were still positive at day 36. And of those, almost all were negative. So of all 9 patients, 8 out of 9 have been MDRO negative at their last time point. So just to sum up, is FMT just used for recurrent C. difficile infection? I think you can see why we said that is pants on fire, false. So moving on now to our last myth, bacteria are the only active component of FMT. So we're full with 52% reporting pants on fire, which is nice. So, so yes, I think perhaps we should have thrown in one that was just totally true. But here, you know, there's been a lot of interest it's been primarily focused on the bacterial and other prokaryote taxa in the intestinal microbiome. But unfortunately, a lot of that is just because of how we've been looking. And a lot of the field has been focused on 16S sequencing, which is, you know, a component of the prokaryotic ribosome, which is just not at all looked at viruses or fungi. And as we're moving into more metagenomic sequencing, we're starting to see a little bit more about the viral and eukaryotic fraction of the microbiome. So here's a particularly interesting paper that asked some of this question. Is it just bacteria that are causing a cure or improvement in recurrent C. diff? And this is a group from Germany that in 2017 kind of created their own process for filtering fecal filtrates. And the description of what they're doing is a little bit vague, but it's essentially serial filtration with smaller and smaller pores. But they were, it's very interesting to note that what they found after filtering out all particles that should be well below the size of a bacterial cell is that most of the patients started to mirror the donor at the baseline. So here in this slide, you can see essentially a taxonomic plot with the relative abundance at the genus level. And on the far left-hand side, you can see the donor. On the second column, you can see the patient at day 0, which is followed by 1 week and 6 weeks of follow-up. And you can see that at the baseline for the patient, that they were essentially heavily dominated by these proteobacteria. And then after installation of this sterile fecal filtrate, that they had a pretty marked change in the taxonomic composition. And some of these looked very similar to that from the donor, which raises a lot of questions because, in theory, they were filtering out all of these taxa that were transferred. So in addition to just looking at the prokaryotic taxa and doing some proteomics, they also looked at at what they tried to call the virome. And they were only able to complete this analysis for 1 patient, but they essentially tried to extract viral-like particles from each of these samples. And you can see sort of a similar story and changes over time with the viral particles. And so in the far left-hand column, you can see the donor stool. In the second column, you can see the filtrate, and that these are relatively similar in terms of viral particles. In the third column, you can see the patient stool at baseline, followed by 1 week of follow-up and 6 weeks of follow-up. And you can see that there's a loss of these sort of purple viral-like particles, and that there's an expansion of the others to more closely match that of the donor. So, there are challenges with understanding what exactly is happening with phages when many of them are actually integrated into the prokaryotic genomes. But this is one first look that suggested that it really is not likely to just be the bacteria that are the most active factor. So this was subsequently followed up by another study by Dina Cow's group in Alberta in Canada, who runs a large fecal transplant program. And they took a different approach and essentially used a different data science tool to just look at metagenomes rather than trying to just extract viral particles, which can be fairly labor intensive. And what they did is they saw in this first box, in patients before they had their fecal transplant, that they had a much higher relative abundance of viral reads. And in the second box, you can see the viral reads, the relative abundance from the donor. So you can see that there's much, much higher viral reads in this patient box compared to the donor box. And you can see that after successful FMT, that the relative abundance of viral reads also goes down at the first observation time point, as well as this more remote second time point. So this is one other way of looking, but also perhaps doesn't necessarily answer that question of whether or not it's tractable to say, are bacteriophage something that are contributing something independent of the bacteria? So just a couple more slides here to highlight that it's not just the prokaryotes. There were 2 papers that came out recently that implicated Malassezia in important medical conditions that are probably relevant to all of us. And so this paper looked specifically at the fungal microbiome of patients with pancreatic cancer. And in the microbiome world, there are lots of cute terms like this, like calling it the mycobiome instead of the fungal microbiome, but such as it is. So these authors, what they did is they took a similar approach to that last paper, and they sequenced all of the microbial DNA from healthy samples and then compared that to microbial DNA from pancreatic ductal adenocarcinomas. And that's what's shown here in this kind of bar plot on the left. And you can see that there was essentially a greater than 3,000-fold increase in fungal DNA reads compared to that of healthy patients in patients with pancreatic ductal adenocarcinoma. And this was found within the actual tumor cells themselves. So then they tried to assign taxonomy to these reads. And you can see on kind of this left column of this heat map, samples from the gut. And then on the second column, you can see samples from the pancreatic tumor. And you can see with this heat map that there's a much higher abundance within these reads that are aligning to fungal reads of Malassezia within these pancreatic tumors. The authors then subsequently went on to validate this in a number of mouse experiments. And it does seem like there's a very clear signal that Malassezia is driving the progression of pancreatic ductal adenocarcinoma, at least in some susceptible patients. There's a second paper that came out that also was focused on Malassezia, interestingly enough. And this was looking at Crohn's disease in this setting. And this group, led by David Underhill at Cedars-Sinai, has been interested in this for some time now. But I'll just touch on this briefly to say that, of course, we know that, that the microbiome is composed not just of prokaryotes, but also of eukaryotes. And while oftentimes the eukaryotes that we isolate tend to be things like Candida, that Malassezia has been seen in a number of healthy donors. But what they did in this study is compared mucosal biopsies from healthy patients to those with Crohn's disease. And they found a much higher frequency of mucosal association with this specific taxon of Malassezia called Malassezia restrictus, which they represent here as being a much smaller budding yeast. And they were able to show also in a number of mouse model experiments that through a CARD9 dependent inflammatory pathway, that Malassezia was driving the development of colitis, both in patients with Crohn's disease as well as in mouse models of colitis. So in brief, there's lots of work that's going on, and it's really just as we're moving on beyond 16S that we're really starting to understand a little bit more about the fuller complement of the causal fractions of the taxonomy in the microbiome of these patients. And so that's why we would say that this is essentially false. So we really appreciate your coming this afternoon to hear about what we've identified as 5 potential myths of microbiome therapeutic implications. And just to reiterate them that, again, FMT is not FDA approved. We hope we've made the case to you that patients are actually fairly accepting and many of them interested and eager in a fecal transplant. And at this point, for those of us, perhaps the cardiologists in particular, it's good to say that we're not necessarily safe from diet and exercise. And then, that there's an expanding number of indications for fecal transplant. And that in this last myth, that it's really not just the bacteria we need to focus on. So this particular patient that we started with, she actually was referred to our premix study. And, although she did have a history of recurrent C. diff, she also was noted to have several severe bacterial infections that we noted. She was one of these surprise patients who was found to have 3 different MDROs on her screening stool culture, including a CRE. And all of them were eliminated within her first FMT cycle. So we were glad that she had a good outcome. So with that, we'll conclude, and thanks again for your attention this morning.
So we've said that everything is infectious. Everything may be microbial, though, right? So I have a couple of questions. One is about, you partially answered this, the power of metagenomics and how you're using metagenomics in your current studies. Secondly, the urinary tract, prevention of recurrent urinary tract infection mostly anecdote, but a small case series is really fascinating. Are you looking at that currently in your studies here? And third, probiotics. Didn't say a lot about probiotics. Is there a role at all in probiotics or more tailored FMT, if you will?
These are really wonderful questions and a lot of what we think about. So I'll take the first and third question. So the first question, how are metagenomic approaches helping us in this work? So I didn't spend a lot of time, or tried not to, in taxonomic plots, but that has been a main limitation of a lot of the work to date, is we can say who is in a microbial community, but we can't say what they're doing. And it's hard to say with strain level specificity about how these bugs are changing, because when you pick out a single bug for culture, how representative that is of an entire microbial community is actually not a straightforward question. And so some of our patients, we don't focus on this a lot because it's not one of our primary endpoints of our study, but we help them, we think, in decolonizing them of MDROs. Some of them remain at risk of infection and develop subsequent bacterial infections like a UTI several months later. But we've observed that many of them have more susceptible isolates, but sometimes with the same genus and species of what they had before. So what metagenomics lets us do is say, okay, we have this clinical isolate that's very susceptible to antibiotics, and we had a very resistant isolate, both of the same E. coli. How can we tell the difference? And really the answer seems to be metagenomics. And so we have the isolates, we do whole genome sequencing, and we're starting to take the approach to actually measure quantitatively how representative one isolate is of a metagenome compared to another. So even though that data might be lost in just looking at, how many E. coli do you have, we think we're going to be able to show that FMT allows expansion of differentially adaptive bugs that are more susceptible to antibiotics. The third question of probiotics is also a very interesting one, and another tough area when people ask, should I be eating yogurt? Friends ask that all the time, when they're taking antibiotics. I don't think there's a good answer for that right now from the data, but there was a fascinating paper in, I believe in Cell 2 years ago, where they compared autologous FMT with the administration of probiotics. And then they really just looked to see how quickly patients returned to their baseline after administration of antibiotics. And so interestingly enough, as you might expect, those who were given an autologous FMT returned almost immediately back to their baseline microbial community composition. Those who were not given anything at all, the control group, had sort of an intermediate time to return to baseline. But those who were given probiotics had an extremely delayed return to baseline, and some of them didn't return at all. And whether or not that represents a potential harm to patients is just not at all understood at this point. There is very limited data that suggests it can be protective if you have a good product from C. diff, but again, the full range of benefits and risks is, I think, poorly understood, largely because of industry interest in probiotics.
Yeah, if you want to see the lobbying power of a group, probiotics is quite high. They don't need it. They don't want it to be regulated, for sure. The UTI clinical trial we're sort of attacking it from a couple angles. So we do have an industry partner that's willing that we're submitting an IND using their product, and then we have a protocol with Sahil Khanna at Mayo, where we're doing a multi-center 2-site study looking at people with recurrent urinary tract infections and giving them a product, probably an oral product by capsules, to see if we can eliminate their urinary tract infections. We're trying to understand why people we know that the gut is the source of the bacteria for urinary tract infections, but we're just wondering if sort of with antibiotic pressure, if some bacteria become more urotropic or something, what changes among that to be able to help people with urinary tract infections. And then also, we are the holders of an IND that's looking at our own capsules and giving it to people with urinary tract infections, among other things, that have multi-drug resistant organisms. So we're sort of doing sort of the general population of all comers with recurrent urinary tract infections. And then we also hope to find this enriched population with multi-drug resistant organism carriage. And Mike has been spearheading the lyophilization of poop for that study, which is very exciting. I got a dehydrator at home and a lyophilizer at work. So I got dried everything. So.
One question we have from Grady. Do stool donors get paid? Asking for a friend.
If we can find a good one, I will pay you. So with the exclusion of healthcare workers and the stricter requirements, I don't know, what is our payment? Like $50 per venipuncture? Yeah, and you get the venipuncture like once or twice a stool collection cycle, which is about 6 weeks. So I don't know if we can't coerce you, obviously. You can be on a manuscript with that.
Other questions, comments? This has been great. We have one over here. Roberta.
Quick question first, great presentation. But is there a role for microbial metabolites in the effect of FMTs? You have mentioned various microbes, but you have not mentioned their products.
I'm gonna let Mike answer that one. He reads more.
Absolutely. You know, with metagenomics, you know, the claimed advance is prediction of functional capacity by gene content, and metabolomics and other analytic approaches that you're alluding to at least allow one way of starting to get at confirmation of those hypotheses. And so that is certainly one sort of next step that we're taking. I think we're in line this month actually to get some of the metabolomics initial results from plasma and stool from these patients. So there are some specific genes and functions that have been described in papers as protective, antibiotics, and a number of others that that bacteria and other taxa produce that appear to be protective from MDRO colonization. And we hope to identify these in the plasma and stool of the treated patients.
I want to put a plug in that we could use energetic people in our research group. So if you have interest in leading the UTI study or writing a diagnostic microbiome invited article I just got invited to from Journal of Infectious Diseases, or if you want to be a stool donor, we also have a healthy stool donor project that we're working on too, just to look at the normal reference range of healthy stool. So.
On that note, I will close. Thank you very much.